Is it visible?
Yes, sir.
Yeah. Today we are going to discuss. Yeah. So many of you have already gone through many sessions of palliative care, and most of them they might feel it's palliative care emergencies, right? It's palliative, and the word is emergency. So it feel like it's like a misnomer. Right. Emergency means it needs attention, acute care, as well as the interventions. Right. So has the palliative core principles has been redefined or has been reshuffled at the time of palliative emergencies? So let's, as an introduction part, I have devised like difference between what even in palliative care emergencies, the core principle of the palliative care has never been reshuffled. So in palliative emergencies, we focus on quality of life and also needs immediate attention. In the same acute emergencies, focus on life saving and needs immediate action as well. In palliative emergencies, our main focus is on symptom control, whereas in acute emergencies, symptom control plus improvement of acute condition eventually. Death is inevitable due to the underlying etiology. It could be a chronic condition, it could be like cancer, and in acute emergencies, to prevent death scenario by rectifying the underlying etiology. It could be anything, right? In palliative emergencies, depending upon phases of palliative care, interventions instituted and should be justified, whether the patient is in disease-directed therapy or the patient is having the life expectancy more than 6 months, 1 year, or is at the end of life care, or is very sick. So depending upon the situation of the patient, our interventions should be justified. And in acute emergencies, interventions according to the patient profile, right? So during the palliative care emergencies, certain points need to be kept in mind. What effect will have reversal of this medical condition? What is your medical judgment? What does patient and the caregiver wants? Could active treatment maintain or improve quality of life of patient and family members? These things to be kept in mind when during the palliative care emergencies. Let's go to the case scenarios. Uh, I need someone to volunteer from the participants. The patient one. Anybody from the participant can volunteer.
Anyone? You can read the case.
It should be interaction, right? Yes. Rather than being the one way, so that you could be the part of it.
I'll read, sir. I'll read.
Okay,
Yeah.
Dr. Ravish, please go ahead.
Please go ahead.
Patient 1, Mr. X, 26-year-old male patient, was diagnosed to have localized PNET of D11 to L1 when he was 12-year-old and was treated with surgery, laminectomy, and excision of extradural space-occupying lesion in 2005, followed by chemotherapy, 10 cycles of VAC and IE, and radiation therapy, 45 GY, 25 fractions in 2006. He was on regular follow-up since then and was evaluated for blurred vision in the left eye and diagnosed to have Ewing sarcoma with multiple skeletal metastases. He underwent extended bifrontal craniotomy, transbasal approach, excision of the tumor, and exteriorization of frontal sinus.
Status post, yeah, SYP is the status post.
Status post palliative radiotherapy to post-operative bed. Status post 3 cycles of gemcitabine plus docetaxel, progressive disease. Status post 3 cycles of irinotecan plus temozolomide, partial metabolic response was noted. And post 6 cycles of irinotecan plus temozolomide, there was still progression. Later one day, he presented with signs and symptoms of severe low backache, which is throbbing, excruciating, intervening ADLs radiating to right lower limb with associated with tingling, numbness, and difficulty to mobilize. Spinal cord compression at D5 level was treated by palliative radiation therapy.
So accordingly, is the history sufficient to further proceed the case? What is missed in the history, and if it is already sufficient history taken is there, what is the next best step you would like to do? The participants among should answer. See, until unless you guys answer, the slides won't move. I won't answer any of these things. So I need inputs from you.
Sir, Dr. Lorna is saying pain relief.
Pain relief, okay. Anybody else?
Participants, please post your comments in the chat box. I can
Or
read
you
out.
can unmute and say something, and you can go back to mute after you say.
So, progression of the disease.
Okay.
Dr.
So
Dr.
whenever we take about the spine history or the spinal cord injury, always the history should be accompanied by bowel and bladder movements, right? We should know whether the bowel and bladder has been affected, or it has been normal, or it is partially dysfunctional. These conditions should be mentioned when you have taken a patient history of spinal cord injury of whatever etiology it could be, right? And we have known the most common metastasis area of whatever etiology from the cancer side. The thoracic vertebra is the most common, followed by the lumbar, followed by cervical, and then hardly we see about sacral and pockets. But the most common area is the thoracic vertebra, where most frequently prone to the metastasis by most of the cancers. It doesn't mean that it won't spread to others. It will go to definitely multiple metastasis. So what is the next best step? Like, how do you evaluate the patient? How do you manage the patient? Is that or anything else you would like to do in this case? Participants, so how do you evaluate the patient? You can unmute and you can talk. Instead of chatting, you can talk. Anything, there is nothing wrong if you don't know or if it is being wrong, right? We all are learning, and the phase has the same turbulence of correct and wrong answers, right? Anybody, how do you want to evaluate the patient? Anything, whichever, whatever gets into your mind, it's fine. Because it is a spine pathology, is already cancerous. He has this severe low backache. He has received the radiotherapy for the D10, D11. Now he was with D5. So how do you want to evaluate the patient? So before going to the evaluation and management part, let's refresh the signs and symptoms. The diagnosis is the metastatic spinal cord compression, right? We have the 4 red flag signs where you need to be cautious of the metastatic spinal cord. The pain. The pain is very typical in a spinal cord compression where uh, it feels like band-like pain radiating to other sides of dermatome regions, shock-like sensation, pins and needle sensation, tingling, numbness, paresthesia, allodynia, hyperalgesia at times, and poorly responsive to conventional medications, escalating pain, and the pain is more at the resting phase, intervening sleep, disturbing gait. These are the signs of the symptoms what the patient may express to you during the pain. The motor deficits accompanied like weakness tends to be symmetrical most commonly, most severe in thoracic males. Sensory deficits less common than motor deficits, but you do observe the sensory deficits as well. Numbness, tingling, burning, shock-like sensation, unsteadiness are some of the symptoms which you go through it. And the last symptoms which they encounter is the bowel and bladder dysfunction. It's a very late finding. When the patient with metastatic spinal cord compression or the spinal cord injury has taken into the bowel and bladder dysfunction, it indicates that the injury has worsened more or it has been delayed. It is not an acute presentation, right? He has difficulty in passing urine, he has pain, or he may not even evacuate the bladder. So it builds up the pressure in the bladder, it creates the pain. Constipation, which he may not defecate by himself, or the sacral nerves has been numbed, right? And urinary retention, which is then again a medical emergency. So before going into the management part, let's refresh your anatomy, right? So we have the cervical 7 vertebra, thoracic 12, lumbar 5, sacrum 5, fused and 3 to 5 coccyx fused bones, right? This is our vertebral column. You need to know which the spinal cord level and the which level the it innervates the muscles, because you need to know the motor and sensory deficits. So you need to know which vertebra, which spinal segments have been innervating. So this is a table. It's a refreshment of your anatomy, where which level innervates the which muscles, so that you can examine and make it clear of it which muscles or which dermatome it has been involved. This is the relationship of the spinal cord segments related to vertebral number, right? Because the spinal cord is shorter than the vertebral column, the spinal cord segments do not correspond numerically with the vertebral that lie at the same level. Among the participants, can you say at which vertebral level spinal cord ends? I'm talking about the adults, not the pediatric ones. Anybody?
L1.
All are doctors, right? So it should be, so you should know where the spinal cord ends, right? In adults, I'm not talking about the pediatric, just forego for this session regarding the pediatrics part. So at L1, L2, most commonly at L1, we demarcate as the end of the spinal cord, right? So how do you make sure of the spinal segments innervating the cervical vertebra? This is how it's like a mathematical calculation for the cervical vertebra to know which spinal segments innervating. You need to add 1. For the upper thoracic, add 2. Lower thoracic vertebra, it is the spine. You have to add 3. So for the lumbar vertebra, the sacral coccyx segments are involved. This is a short calculation part where you would know the C1, C4 level and the spinal segments are the same. When the from C4 to T3, you need to add 1 for the spinal segments involving. That is, for the C4, C5 spinal segments are involved. For the T3, it is the T4. So plus 1 you add it. For the T3 to T6 vertebra, it is plus 2. The spinal segments. When you know these segments, you know where this dermatomes are reached. Accordingly, the vertebra lesion is there. The spinal segments, whichever involve the corresponding dermatome, the muscles have been impaired function. So the first and foremost, when a patient is diagnosed with metastatic spinal cord compression, he should take the whole spine MRI within the 24 hours, ideally. Right? He should be admitted to the hospital. You should use bed rest with log rolling, administer dexamethasone 16 mg. Along with steroid, we need always accompany the proton pump inhibitor, provide educate analgesia, and once spinal cord compression is confirmed, definitive treatment within 24 hours of confirmation should be done. After post spinal cord compression sets in, after post like 48 hours, the paralysis definitely sets in. So we need to delay the process or avoid the process, whichever is the best scenario for the patient. So we need, when we do the examination part, when we know the spinal segments where it has involved, we categorize the patient as this is the Frankel classification. It's an old one. Based on this, A to E category will be there. The new classification which everybody uses is the Asia scale. It is an American Spinal Injury Association scale, impairment scale, which grades based on the Frankel classification, grade A to grade E. Grade E is the normal like us, and grade A is the complete loss of motor and sensory function, right? So based on this, we oncologists, we physicians, we have a framework which is called NORMS framework for the spinal metastasis to manage. So it stands for neurologic, oncologic, mechanical, and systemic. So whatever next best therapy for the patient to be given in an ideal situation where all the resources and all the manpower or all the ideal situations are available. So this is the framework for the physician to go through, whether the patient should go to surgery first or the radiation first or surgery followed by radiation, right? The same framework I have tabulated here, which you can go through. Low grade ESCC without myelopathy. ESCC is epidural spinal cord compression. It's an MRI finding, right? Even in high grade epidural spinal cord compression with myelopathy, if it is radiosensitive, you no need to go for a surgery. You can straight away go for a conventional EBRT. EBRT means external beam radiotherapy, which is like the machine is like a CT scan machine, but with high dose radiation. And there are different machines and different softwares. As low as the normal machine can suffix to treat the patient, no need any hi-fi end machines for this particular type of palliative radiotherapy, right? So in order in the NORMS framework, we need to know what is ESCC, right? It is an epidural spinal cord compression scale. It's basically an MRI interpretation, which assess the degree to which vertebral body metastasis compromises whether cord compression is present or not. It may serve as guide as to when intervention, which intervention, whether radiotherapy or the surgery or whichever is helpful. So there are grades of grade 0 to 3. It's MRI interpretation, radiologist interpretation, where grade C is the very severe, grade 3, which is spinal cord compression, grade 0, it is only bone erosion type, it's not sets into the CSF. And among the NORMS framework, we have which is radiosensitive, which histology is radio resistant. So radiation sensitive tumors like highly sensitive are the myeloma, lymphoma. The moderately sensitive are the breast. Moderately resistant are colon and non-small cell lung cancers. And highly resistant are the thyroid, renal, melanoma, and sarcoma. These are some of the studies which they have said based on different studies where radiosensitivity that metastasis do respond or have favorable outcomes to radiation. Like breast, most of the studies they are in the favorable group. Lymphoma, seminoma, myeloma, all the studies have said they are favorable and it is worthy to go straight away with the radiation rather than waiting for the surgery. And prostate, almost it's a favorable thing. It's a green signal for the radiation to go primarily if the patient is not tolerable to surgery or there is surgical contraindication or the lesion is stable but he has symptoms, right? So these three are very common and most commonly you can go for the radiation. If radiation is delivered within 48 hours of spinal cord compression, the paralysis can be delayed and we can avoid that paralysis to set in also. So as the number of days increases, the outcome as well as the efficacy of radiation also has limited power. So regarding again in the NORMS framework, we have the stability. So how do you find the stability, whether stable or instable? It is again MRI scoring, MRI interpretation. Based on this, they have developed the scoring where 0 to 6 is a stable, the stable which gives us the idea. Potentially unstable, the risk of surgery, risk of instability and surgery is potentially valid. In unstable, like in 13 to 18, straight away, if the patient has ideal conditions, no contraindications of surgery, he has better performance scale, and he can straight away should go to the surgery with or without the radiation, depending upon the profile. And there is another parameter which is systemic, right? Which we are talking about, whether the patient performance scale is fine, whether patient is non-cachexic, he is able to do with support at least, or is not completely bedbound, or a paraplegia sets in, or is hemiparesis or paraplegia, or the condition of the tumor is it progressed to everywhere and the life expectancy is less than 1 month or 10 days, or is the condition is like impending death situation. And at that time, whether we have to go for the intervention, we have to go for the radiation, it's an ethical dilemma, right? So how do you manage the patient? So it's a total pain concept. It's multidisciplinary team illness focused care from dealing with radiation oncologists, spine specialists. We have emotional turbulence, psycho-oncologists. We need physio, occupational rehabilitation therapists for the maximizing the independence, nutritional care. Of course, the palliative medicine specialists or the physicians at primary, secondary, tertiary levels do have a much more significant role in illness focused care. But this is not just limited to them. Even the compounder who changes the bed sheet, who transfers to the wheelchair, from wheelchair to onto the bed, who takes to the radiation machine, the technicians, the sweeper, the watchman, the security guard. So all these also a part of our multidisciplinary team. So accordingly, how do you manage the treatment? The radiation, 8 gray, GY is a gray. GY means it's a dose like centimeter and meter. How do you specify the height, units of height, kgs and grams in weight? This is how, if any profile of the person or any case summary, if you have seen like GY or something, it is called the dose of the radiation which has been given to the patient. Right, so GY means gray, it's an SI unit. 8 gray in single fraction or 20 gray in 5 fractions is the same. It's a short course if the patient profile is very febrile and is not able to bring back the patient again. A single fraction is sufficient to relieve the pain. If the patient profile is good, his outcome is fine, he's only having bone metastasis and rest of the tumor has been regressed comparatively and no other metastasis elsewhere, his profile is better, then you can go for the long course treatment. That is 30 gray in 10 days we give. Saturday and Sunday we don't offer the radiation. So 5 days, weekly 5 days, or it could be in 15 into 2.5 or 20 into 2 gray. These are the doses, various doses are there. And any dose is equivalent. There is no superior and inferior dose. A single 8 gray is sufficient to relieve the pain of the patient. SRS is an high-fi technique where instead of number of days, it is a single shot, like a surgery. At a stretch, only one fraction high dose is given to the particular area. It has its own indication. It's a single high dose to the lesion. So we are talking about the surgery followed by radiation also. So what are the, when can you be considered for surgery? For the patients who are expected to live more than 3 months and a gap of at least 2 weeks post surgery, when can you take up for the radiation? But it again depends upon the healing process of the patient, diabetes, other comorbidities. So the minimum is minimum of 7 days or 2 weeks time you can take the interval and can go for the radiation. And of course, highly radio-resistant tumors with unstable definitely is a typical indication for surgical treatment. And medical, we have high-dose steroids, dexamethasone. Always a steroid is accompanied with proton pump inhibitor. Any proton pump inhibitor is okay. Do not forget. And WHO step ladder analysis. And of course, the supportive care measures like PC, enema, supposed breeze, hydration, non-pharmacological interventions like psychologist and rehabilitation do play a vital role in illness-focused care. So as we are talking about the step ladder analysis, I don't want the participant to be silent. So please explain if the patient is accompanied with 4/10 or 5/10, which analysis you would like to prefer along with the co-analysis like DEXA has already been there, PPI has already been there. So only specific to analysis. If the patient is having 5/10, based pain class has been already over, right? Hello?
Yes, doctor, it's over.
Over. So the participants should say if the NRS score of 5 by 10 based on the WHO step ladder. See, if you get delayed, the case presentation will be delayed, right? So which analysis would you use? Anybody can unmute and say, please.
Tramadol.
Okay, tramadol. And after tramadol, post tramadol, after reaching the maximum capacity, also if the patient having the pain score of 8 by 10, what would you like to do?
Step 3 will start.
What would you like to do? Even after tramadol, he has not been relieved and the pain has been increased, like 8 by 10, for example. What would you like to do?
Morphine can be started.
Okay, how do you like to start morphine? Of course, the patient is admitted, is in front of you. So how do
Give
you like to,
IV trials will give us.
so how do you give the IV trial?
Uh, will dilute in 10 ml NS and
Okay, one ampule of morphine, how much in your center? I
sorry,
mean the dosage, not the cost.
10 mg.
Huh?
10 mg.
10 mg and we also get 15 mg. Okay, in both, some centers has only 10 mg. So how do you do it? Morphine trial, you dilute and give. How do you give?
In 10 ml NS,
Yeah.
and then we'll give 1.5
Mm-hmm.
at 10 minutes interval.
Okay.
And then we'll see the toxicity. If then we'll
What
stop
toxicities would you
morphine toxicity.
record?
Like morphine toxicity.
What do you like to know during the trial?
The
There are
respiratory
multiple
rate.
morphine toxicities. Which one you would like to know?
Respiratory rate, shallow breathing.
Okay.
Sir, either ask for pain relief,
Okay.
a decrease in NRS score, or C for drowsiness or respiratory
Yeah.
depression.
So before starting the morphine trial, you need to have a list or a tabulate, drowsiness, respiratory rate, and the pain score baseline. Then every 10 minutes as you go on giving this trial, at certain, you would notice every 10 minutes how the drowsiness and the pain score and the respiratory rate you correlate. And based on this, at certain dose, the patient gets released. And you will stop the trial. So how do you convert that into an oral? Now you have set the dose. For example, you have used 10 mg the dose. He has relieved of pain and the drowsiness was 2 by 10. Respiratory rate was 20. So all the parameters were ideal. You can start the morphine. So how do you like to convert into an oral? He's able to swallow. He's young. He's fine.
Fourth hourly will give.
So how do you convert the dose? So already morphine prescription has been taught to you. So if you want to write the morphine, what do you need? How do you convert the dose from IV to oral? 10 mg IV dose you have fixed. So how do you proceed for oral morphine?
Three is to one, sir.
Pardon?
5 mg Q fourth hourly and
3 to 1 ratio.
No, pardon me, I couldn't hear you.
Sir, morphine orally 3 is to 1, sir. IV 1 and morphine is 3 times the oral IV.
Okay. So here is the catch. When you convert the 3:1 ratio is for the continuous IV infusion, right? We are not giving the continuous IV infusion, it's a trial. So whenever you give the trial like this basis, like every 10 minutes, when you want to convert into oral, it is a 1:1 ratio. So if the patient 10 mg is, the pain is subsided, he is to be on 10 mg Q4 hourly plus 10 mg S1s. If it is a continuous IV infusion, Yeah, it is a 3:1 ratio, right? And always accompany your laxatives, your paracetamol, your WHO step 1, and always avoid tramadol. And perinorm can be given instead of FMCET or the olanzapine for the anti-emetic part, right? And if the same 10 mg Q4 Tarly, so how do you, his pain is settled with the 10 mg Q4 Tarly, and now you want to convert into SR. How do you want to do convert into SR?
30 mg
Okay,
BD
30 mg SR BD, right? So what is the SOS dose for that IR?
total
SR,
60 mg we are getting.
yeah,
We'll convert them to SR dose.
yeah, 30 mg SR BD, what you said was right. So what is the SOS dose in between
SOS
if you
dose
get,
would be 10 milligram.
yeah, 10 milligram.
So
So
calculate
if,
the total dose divided by 6.
yes, and if he is comfortable with that SR and now he doesn't want to have the uh, pills and he prefers patch and dose is established, is stabilized. So which patch would you like to convert and what is the dose you would like to give and what is the morphine IR SOS? So 30 mg SR BD, the total is the 60 mg. You want to convert into a patch. Which patch would you advise? Is not cachexic, all the ideal indications for the patch is available. So what would you do? There is no affordability issues. There is no deficiency of the resources in your pharmacy. What would you like to do if the patient seeks for a patch, transdermal patch?
Fentanyl patch.
Yes. What could be the dose? What is the dose you want to give? How do you convert oral morphine to fentanyl? If a patient is on 60 mg per day, what is the strength of the patch would you like to give?
$30 mg.
Fentanyl comes in 12.5, 25, 50, 75, and in abroad 100 as well. I haven't seen 100 in India. 75 is the maximum I have seen. So how do you arrive at 30?
25.
Hello, how did you arrive at 30?
So fentanyl is more potent than morphine, but it takes a
Yeah, you have a calculation part which you can do, which been already been discussed, or a shortcut form that is a maximum, I mean, total dose of oral morphine per day divided by 2.4, which gives you the fentanyl strength, or by 3, which by 2.4 it gives you the ideal way. So 60 by 2.4 is 25. So you prescribe the 25 mics, which releases slowly and daily, and the patch works only after 12 hours. So you need to be cautious. For the first 12 hours, you need to follow the daily dose of the morphine, and then you wean off SOS dose, and the SOS dose will be 10 mg SOS, right? Okay. Now, as we are talking about the steroids, I would like to add why dexamethasone is preferred, because it is having zero mineralocorticoid activity, as you can see, and the anti-inflammatory effect is the maximum among all. And there is a conversion for your sake, you can go through it from prednisolone to dexamethasone, this one. And apart from the pharmacological non-pharmacological exercises, which exercises should be done in metastatic spinal cord, which should not be done. For your reference, you can go through the table. So the complications of spinal cord injury, it could be neurogenic bladder, neurogenic bowel, autonomic hyperreflexia, spasticity, pressure ulcers because of we can't able to mobilize, cardiovascular complications like bradycardia, venous hypertension, respiratory problems. You could have shortness of breath, metabolic and endocrine abnormalities as well. So there are certain challenges with respect to patient tumor as well as treatment. That is the functional impact of the symptoms, patient preferences, and physical location of the patient. That is distance to travel to hospital for surgery or radiotherapy is also a challenge for many. And the tumor histology per se. Sometimes whatever medicine or the therapy you give, there are refractory cancer cells are refractory to the treatment, and it sometimes make hard for the clinician as well as the patient to go through the cancer journey. And the treatment factors, there are technical surgical factors, radio responsiveness of the tumor, toxicities are also expected from the treatments, and predictive outcome from the active treatments should also be taken into consideration. So oncology and palliative care are the two sides of a coin. They are inseparable and they should always be accompanied. Right? It's like a teamwork effort because the therapy change could be there. Like stem cell transplant is a curative option for this boy, which we couldn't offer. It's already metastatic, and bowel and bladder issues are there. Catheterization, then catheter-related infections, leakages, constipation, all these things are to be discussed, and emotional and therapy support to patient and caregivers as well. Such patient as the boy is very young, there's a lot of emotional turbulence among the parents, siblings, as well as the patient per se. So caregivers' concerns also need to be explored. They should not be left, they shouldn't be abandoned along with the patient. They should also need psychological and emotional resilience. Of course, financial, logistic, and basic amenities to be explored and intervened. Everywhere the ideal situations or the ideal circumstances may not be there. So you need to be justified which therapy or which treatment is benefit to the family and the person per se. So follow-up visits to be aligned with oncology consultation to avoid inconvenience. Right, the patient too. Anybody from the please volunteer. Please kindly go through it fast. We already. Okay, nobody is interested. Let's go. 60 years old with COPD, presented to emergency department with severe breathlessness with cough and hemoptysis. Pain in the right chest radiating to back, unrelieved with nebulizers and OTC over-the-counter analgesics. So on examination, conscious and coherent. Face and neck swelling distended with neck veins. On chest X-ray reveals 7 into 5 centimeter mass in right lung, encasing the vessels, and no effusion noticed. What is the diagnosis? What is the emergency? I mean, it says here lung cancer, carcinoma lung, we understood. What could be the diagnosis of this emergency? Anybody?
The superior vena cava syndrome.
Yeah, it's the superior vena cava obstruction. So how do you manage? So for your reference, I have given the etiologies where not only malignancy, non-malignancy is too prone to superior vena cava obstruction. What is the normal CT mediastinum and how it could be in the superior vena cava? It is a classification grading system to identify the grade, which is fatal, which is asymptomatic. Accordingly, we can be placed into the emergency situation. This is another Yale University scale, but most commonly we use the use classification. So the treatment options include general measures to surgical interventions. So general measures are head elevation, always steroids in the first 8 to 16 mg per day. Steroids are always accompanied with the proton pump inhibitors. If there is a thrombosis on your ultrasound, we initiate anticoagulants. Pain, analgesics. If SOB, breathlessness is there, Despite with DEXA and everything, opioids can also be initiated. So specific treatments like radiation, 20 grain, 5 fractions, 30 grain, 10 fractions can be given. If it is a chemosensitive tumor, single fraction 4 gray is sufficient. So as we noticed that complete relief of symptoms in chemosensitive like NHL and small cell lung cancer in 80% and non-small cell in 40%. In endovascular therapy can be given for patients diagnosed with mesothelioma who are not much responded well to RT and CT. Surgery indications are very less. We usually reserve for thymomas, which tend to be radiochemo resistant, but we not commonly employ the surgery things. The first three are commonly used, either radiation or if it is a chemosensitive, we start with the chemo and endovascular therapy for mesothelioma patients. You can go through the algorithm. Okay, 42 females gave ovary post-op chemotherapy recurrence. Stage 4 presented with whole abdomen pain, distension, vomiting, constipation for 4 days. Associated with early satiety with small meals, anorexia and bloating. On examination, general conditions, suboptimal fare, no icterus, no pallor, no edema, no cyanosis. So she was conscious and oriented to person, place, and time. Per abdomen, mild fluid but not elicited fluid free, tenderness in the whole abdomen, and hypoactive bowel sounds and auscultation. What could be the diagnosis of this particular emergency? Anybody? It's an ovary patient, recurrence. There has bowel, abdomen pain.
Bowel obstruction, malignant bowel.
Bowel obstruction. So what would you like?
obstruction.
Yeah, what would you like to do? How do you manage?
Surgery is not possible.
So the first step would you do is an chest X-ray.
Right tube insertion, sir. Right tube.
Abdomen. The first thing you go for the imaging to confirm whether our clinical suspicion correlates with the imaging process. So CT scan is very ideal, but at times we need to know whether the patient vitals are stable, patient is in a condition to go through the IV oral contrast. So X-ray is cheaper, simpler, available in most of the facilities. And you need to order the technician to take the X-ray from the diaphragm till the pelvis. Why? Because if there is a air under the diaphragm, it indicates what? Anybody? If there is a air under diaphragm, what does it indicate?
Obstruction.
It indicates perforation, right?
Perforation.
It becomes a surgical emergency per se. So you need to tell the technician to take from the diaphragm to not just the bowels. So if you take only just the bowels, you may miss the perforation part, right? So the objectives in this case, you would like to know whether it is really a bowel obstruction. If it is obstruction, whether it is partial or complete. What are the site of obstruction? What is the cause? Is this complicated or simple? Can anybody say what is partial and complete obstruction? Yeah, we confirmed it is a bowel obstruction. If it is partial or complete, what would you do? I mean, how do you define it is partial and complete? Because our medications do alter one or two based on this.
Partial, there will be bowel movements will be present, sir. However, in complete, there won't be any bowel movements.
Yeah, so bowel movements, the patient can pass flatters. She may have pass stools, at least hardened stools. It could be partial obstruction. Complete, the patient may not pass flatters at all. Complete constipation. So this is to be noted. And complicated, as I said, it is perforated associated with obstruction. Like perforation is the cause for the obstruction, is in septic shock or septicemia associated. So it undergoes the complicated obstruction. So site of the obstruction, if it is high and vomiting will be early. If it is low, pain with distension is possible. Small bowel, large bowel, the constipation is the presenting symptom. As I said, if it is strangulated, shock, rigidity, rebound, tenderness would be flared up. the patient may present with mixed symptoms. We may not have labeled as what we have discussed, but these are the symptoms which you can clinically pick it up. So these are the X-ray. What would you see? The large bowel obstruction. What are the findings? How you differentiate? This I would like to know. Bowel obstruction versus ileus, because paralytic ileus could be there in our patients because we use morphine as well. So you should be aware of it. In paralytic ileus, there is a gas is seen in the rectum. Unlike where in obstruction, there is a paucity of gas in bowel beyond the site of obstruction. But in paralytic ileus, you will see gas in the rectum. These are the features of the small bowel obstruction. You should know the normal diameters of the small bowel, 3 centimeter, colon 6, and cecum 9, 3, 6, 9 rule. So the goal is assurance to the patient and family that we are going to do the best to relieve our symptom as much as possible. Correct the correctable always. So go see the electrolytes, NG tube for aspiration, medications, and what important history would you like to ask in the bowel obstruction is sometimes the patient says that she is having multiple episodes of loose stools, and when she says this, it is not exactly the diarrhea or the loose stools, it is the leaky stools because of the obstruction, the liquefaction of the stool coming out as the liquid, and she's going or leakage of the stools. We call it as spurious diarrhea or overflow diarrhea or paradoxal diarrhea. If the patient says that I'm multiple episodes with this presentation, multiple episodes of loose stools, you need to ask specifically whether motion is associated with that stools or only the white discharge, or it is having smell, or in this way you would understand it is the paradoxal diarrhea. Don't administer anti-diarrheals. So pharmacological therapy, what should be avoided, care of the patient and the caregivers. The severe pain always accompany with the opioids. To decrease the secretions, we start hyoscine butyl bromide, which is available and cheaper, either IV or the subcutaneous. Injection glycopyrrolate is also helpful. Instead of when we start anti-inflammatory steroids, the better PPI would be ranitidine because it acts as PPI as well as the anti-secretory, which decreases the distension of the bowel. So instead of pan-top, it's better you add injection, which covers both this stuff. And antiemetics, if it is a partial obstruction, you can go for the metoclopramide IV. If it is a complete obstruction, you should avoid metoclopramide and should start on haloperidol, which doesn't have prokinetic agent. And laxatives per rectal examination. It's not just PC enema. You need to do finger evacuation followed by PC enema. So it's a symptomatic overall management, multidisciplinary team, emotionally support, hand-off life care, dietitian, nursing care, and procedures. If the surgical interventions do help and the patient life expectancy could be more, you can go for the surgical interventions as well. So Mrs. D is a 48-year-old woman who was given a diagnosis of IDC breast carcinoma. Hormone receptors are positive and HER2 receptor is positive with 3/31 nodes positive. Treatment at that time involved breast conservation surgery followed by radiotherapy and chemotherapy. 13 years later, she was given a diagnosis of breast cancer recurrence with liver metastasis that was positive for the receptor status, ER and HER2, but not for progesterone. Other than the liver metastasis, CT of the brain, just no other remarkable findings. A bone scan showed severe foci of abnormal radiotracer accumulation consistent with degenerative changes as opposed to metastatic disease. She was presented with non-specific symptoms such as anorexia, nausea, vomiting, polyuria, dehydration, pain, weight loss, fatigue, muscle weakness, irritability, and inflammation. Can anybody say what could be the diagnosis? So it is hypercalcemia. It is a management of hypercalcemia. It's an algorithm. How would you deal with the hypercalcemia? The normal saline bisphosphonates are used for malignancy associated hypercalcemia. And based on the serum creatine, that is creatine clearance, those modification of the glucuronic acid is given. Generally, in ideal cases, there is no optimal creatinine clearance, it is the 4 mg dose, which is given 3 weekly, right? And denosumab is a rank-ligand receptor in the monoclonal antibody, which is given when there is a compromise in renal function. It is safe in renal failure patients. So 50 years male post-treated case of recurrent carcinoma, buccal mucosa with varicose node bleeding. So how do you manage the patient? What necessary steps will you advise the caregiver if patient is at home? What is the anticipated care? So the step one is the risk assessment. You need to know the site of the bleeding, signs and symptoms associated with bleeding, whether it is pain, is associated, foul smell, exudates, or is it a small warning bleed, or it is a terminal event of bleeding. Is he on any drugs that inhibit coagulation, or he is having thrombocytopenia because of marrow infiltration. So step two, harmful reduction, harm reduction, that is multidisciplinary team approach. You need to do radiotherapy or cauterization, embolization, supportive care. You identify the triggers, whether he's in panic. You need to give benzodiazepines, relieve the panic state. The perceived risk should be shared with the caregivers, and if they give consent, can be shared with the patient. Right? Medical care, supportive care accordingly. And advanced care planning, intent of the ongoing therapy which you are going to provide. You need to discuss the goals of care, what is the aim of your treatment, and what these medications or this therapy would achieve, what are their expectations, what could we expect. Living will if possible, medical decision if patient non-competent, then who is the next medical head or who can take decisions. AND, it is called allowed natural death. The DNR word not much into caregivers may feel that they're weaning off some important therapy, like do not resuscitate. So it has been changed to allow natural death. It has been rephrased. So the radiotherapy can be a very important role. 40 grain 15 fractions or 30 grain 10 fraction or a single 8 gray sufficient for any palliative radiotherapy. Right, what we actually do, we doesn't have any hemostatic gauze, so we use the 5 to 10 ml of adrenaline and apply to a gauze tab, which can be applied with pressure for 10 to 20 minutes. An alternative tranexamic acid injection, soak it in the gauze. You can apply over the wound area for 20 to 20 minutes. And to reduce the panic or reduce the anxiety, you can give injection midazolam as well. If the patient buccal, you can even consider, if not IV, there is no secured IV line, you have to consider for the buccal midazolam, which fares well. You need always you need to have the emergency drug box checklist, and also you need to send the patient home with the crisis box. Right. So what is the crisis box? You have to dark colored towels, bed sheets, blankets to soak up the bleed, pre-filled sedatives and analgesics. It is the crisis box which you need to advise the caregivers at home. Right. Anticipatory events which could happen. This is the last one. A 47 years old female CA cervix, post-treated case with recurrence on palliative chemo. She presented with chief complaints of backache, specifically at the post-irradiated area, L1, L3, without cord compression or pathological fracture on imaging, which was radiating to left lower limb. The NRS score is 8 by 10. The nature is dragging, burning, tingling type, continuous pain, aggravating on movement and relieving on the rest. How would you manage her pain? So this is the WHO ladder, which we all know. I just want to introduce the word refractory pain through this case. She was admitted and started on injection morphine titration. She was given fentanyl, but still her pain hasn't come down. So refractory pain is something which is defined as pain not responding to standard opioid therapy, with or without co-analgesics like steroids, gabapentinoids. All these are the co-analgesics, right? So according to a study, refractory pain is defined as unsatisfactory control of pain even with standard opioid therapy, taking oral morphine equivalent of more than or equal to 300 mg daily for more than 1 day. In other studies, they have mentioned more than 200 mg also. The main thing is that the pain which is not relieved with the conventional opioid therapy despite escalation of the opioids. So then you need to opioid switch to patients with pain refractory, poorly managed side effects, logistical or cost concerns, trouble with route of administration or absorption, you need to switch opioids. So I just want to introduce that it's a wonderful drug. Fentanyl also helps in neuropathic pain, but it is costly, the IV as well as the patch. Methadone is cheaper as the morphine, but it has its own barriers. Like most of the healthcare facilities may not have methadone, or the physician may not be much well versed or not experienced of methadone. Right, these things are to be taken into consideration. This is the calculation part which can help you if the patient is on morphine. How would you like to convert into a methadone? Methadone beautifully it reduces the neuropathic pain, mixed pain, as well as it is very much safe in renal failure as well as the liver failure patients. Despite the patient is on methadone, her pain doesn't come down. We have started lignocaine infusions as well as the burst ketopoint protocols. This I want to introduce. This WHO 3-step ladder has been modified into step 4. Step 1, as you already know, 2 and 3. The step 4 is the nerve blocks, spinal stimulators, epidurals, intrathecals, all these things. It doesn't mean that nerve block should be given at the end. It can be given in the step 1, as the ladder doesn't say that start give with paracetamol. If it doesn't have any effect, then go for tramadol. Then it's not that ladder, right? If the patient, even in opioid naive, a patient presenting with 8/10, you straight away start with the stronger opioids, that is morphine, whether oral or IV, depending upon your facility and the experience. Similarly, step 4 can be started if the more of the nerve, it's because of the peripheral nerves or the neuropathic pain, and more of neuropathic pain than of mixed pain. Straight away, step 4 can also be given depending upon your healthcare facility and this. So this is how in an algorithm how neuropathic refractory pain can be given, which we have given the intrathecal. Actually, we thought of giving for the epidural morphine, but the patient is not in a way to support, like 6 and 7 members have to come and support her to be in the sitting position for the epidural, but the anesthetist slipped because of her discomfort. She has moved. It slipped from epidural to intrathecal. So we have given the intrathecal morphine, and for the 2 days, she has been pain relief and passed away with less torture. So the take-home points are: treat the symptom, treat the person and the family. You correct the correctable, right? And the ultimate aim is the quality of life rather than increasing life expectancy or clearing of the underlying etiology or inhibit the progression. The main thing is quality of life. Based on this, these points should be remembered while you deal with the palliative care emergencies. And the conversion ratio, which I would like to say, for IV is to epidural is 100. IV is to epidural will be 100:1. You can note it down. Second. So IV is to epidural is the 10:1 ratio, and IV is to intrathecal it is 100:1. Right? That is the neuroaxial opioids. For IV is to epidural, it is 10:1. So what we have discussed today, the neurological emergencies, cardiovascular, GI, metabolic emergencies, hemorrhage, and pain crisis. So the palliative care spectrum of care doesn't end with the perceive the treatment. It includes advanced care planning, goals of care, decision making, as well as the education, psychoeducation to the patient, caregivers, counseling to the patient and the family, and of course, it follows the bereavement care. These are some of my references, and I just want to end my slides with a quote by Dr. Patch Adams. You treat a disease, you win, you lose. You treat a person, I guarantee you You will win no matter what the outcome is. Right? Palliative care is an amalgam of compassion and practical wisdom. Thank you.
Thank you, Dr. Ravikiran sir. So we had one comment from Dr. Atasia. So she was asking you to repeat. Dr. Atasia, can you please unmute and say what you want Dr. Ravi to repeat once again?
Hello. Hello.
Yes,
Yeah, yeah.
yes,
Yes,
please.
I wanted that IV ratio 10 is to
So
1.
the neuroaxial opioids which we convert from IVs to epidural, it is 10:1. And IV is to intrathecal, it is 100:1. That is, for example, if the patient is on IV, for example, you say 1000 mg per day, the equivalent epidural dose per day will be 100 mg. And the
So
same
IV into intramural is 100 is to 1.
epidural 100:1. In intravenous is to epidural is 10:1.
Okay.
Intravenous is to IT, that is intrathecal 100:1.
Okay. Thank you.
So if it is 1000 mg per day IV, the patient equivalent epidural dose becomes 100 mg. And the same equivalent intrathecal dose becomes 10 mg. Right? In this way,
Yes.
we convert if the patient, after neuroaxial opioids, if the patient sustained and subsided pain, then we convert again into the IV. And from IV, if she is again stabilized and she's able to, pain is weaned, we can again convert into oral. So in this way, we switch the route of the administration of the opioids, depending upon the patient profile. So even if neuroaxial opioids hasn't worked, you can go for the nerve blocks, right? Depending upon the expertise and the facility of your center. As our India is not blessed with resource enhanced, we are everywhere the challenges and barriers, resource limited setups. We need to have a tailor-made approach and do the best as much as we can do. And some patients we do not have anesthetists who have experience in neuroaxial opioids, or nerve blocks cannot be done. You have only oral morphine, not IV. So there are many challenges, and some centers they do not even have opioids at all, right? So there are many constraints, and we cannot follow the book in every case. You need to make your own notes. You have to make tailor-made approach for the particular person instead of the patient, right? So the person includes the illness plus the family, and you need to judge, weigh the medical ethics, whichever is justified. I hope it's clear. I think we have a presentation.
Yes,
I don't want to delay the presentation.
Yes, we can.
Doctor, who is supposed to do, please go ahead.
Yes, sir. Can you share it?
Yes.
Good afternoon, everybody. So I'll be presenting today's case. This patient is Inas Pereira, male, around 60 years, had come to the primary health center with a diagnosis of CA prostate with mets to spine, which was recently diagnosed. So he came with complaints. Initially, his complaints were that he was a known case of CA prostate with history of back pain since few days. The pain was constant, severe, and not radiating. It was dull, aching type with burning sensation of both the legs. This pain used to keep him awake throughout the night, and sometimes he could not feel his legs. He had a urinary catheter which showed blood in urine, with fever on and off, with chills. The history of the illness was like he had a history of dysuria since many years, poor urinary stream, with urgency and maturia. Ultrasound prostate was done, which diagnosed as enlargement of prostate with significant post-void urine, with severe increase in PSA levels. Here is a known case of hypertension and diabetes and IHD on clopidogrel. Patient did not give consent for any surgeries, hence he was catheterized and given oral medication. Since past 6 months, the patient complained of backache with difficulty in walking. This pain slowly progressed and increased in severity over 2 weeks. Patient visited nearby hospital for pain relief, where he was given a trial of epidural anesthesia with morphine. However, he could not afford the treatment expenditure for more than a week. He was then directed to palliative care at Ponda for pain relief, where he was prescribed with tab morphine 40 milligram per day, TDS. However, since 2 days his pain has increased and he is not able to sleep throughout the night with loss of sensation in both the lower limbs. On examination, this patient is an elderly male, thinly built, febrile, and had pallor. Pulse 60 per minute with BP of 90 by 50 millimeters of mercury. SpO2 was 94% at room air. Respiratory rate was 24 per minute. On respiratory system examination showed bilateral clefts. CVS was within normal limit, and CNS, he had sensations which were decreased in both the lower limbs. The significant treatment and significant investigations. Hemoglobin was 8.5 grams. Total count 14,000 with neutrophils of 80 and lymphocytes of 20. Blood urea 60, serum creatinine 2.8. PSA levels was 98, and MRI spine was done, which showed evidence of osteoblastic lesions. Psychosocial aspects. This patient is around 72-year-old male staying alone in the old house with no source of income. His neighbor looks after him, who is also old and stays with his wife, with pension as the source of income. Earlier, he used to sit in his friend's shop part-time and he would earn around 300 rupees per day. However, the severe backache has not been allowing him to sit, which is causing him frustration of relying on his neighbor entirely. Presently, he is on antihypertensives tablet amlodipine 5 milligram OD, oral hypoglycemic agent metformin 500 milligram BD, clopidogrel 75 milligrams, morphine 40 milligram TDS. Regular catheter change is done at the primary health center every 15 days, and on syrup crimafene 15 ml at night. His main concern is pain with a severe backache, difficulty in both his limb sensation, paraparesis, and dependency on his neighbor. So to give a summary, it's a 72-year-old male with CA prostate with meds to spine with severe pain and paraparesis, impending paraparesis maybe. So my discussion points are how to relieve the sudden increase in pain which is not responding to morphine, and how to give palliative care during involvement of multiple systems at the same time, and how to manage palliative care emergencies at the primary health center level.
So, from the participants, anybody thoughts, inputs, how to relieve the sudden increase in pain, not responding to morphine?
Methadone is this case possible?
Okay. Doctor, can you go to the prescription of morphine which you have mentioned is 40 mg TID, right?
Yes, sir.
So what is the basis of giving 40 mg TID?
For the severe pain was titrated. Initially was started on 20 milligrams, but then it was increased where he was undergoing treatment like in a palliative care center in Ponda. They had started him directly on, with that he had come with a 40 milligram TDS.
Okay, do you have IV morphine in your center?
No, sir, we don't have IV
You
morphine.
work in
Primary health centers.
Primary health center. Okay. So with this 40 mg TID, first of all, the morphine dose should be given in every 4th hourly, right?
Yes, sir.
because of his increased creatine, you can go for the Q6 Charlie as well, weighing the pros and cons. Along with that, there are no co-analgesics per se. Of course, he's diabetic. You can start the steroid low dose. Instead of 16 mg OD, you can start with 8 mg and you can monitor the sugar levels and increase the morphine or add something other oral hypoglycemic or on insulin till his steroid uh, time frame concludes, right? The steroid will definitely help him. Steroid was missing in your prescription. And as is diabetic, it itself is a trigger stressor factor for the peripheral neuropathy, right? And there is no co-analgesics, like there is no gabapentin or pregabalin, there is no duloxetine, and you can have the, if not the hi-fi stuff, you can start with the methylcobalamin injections, right? IV, IV or the tablet, or if there is a, you can have gabapentin with methylcobalamin formulations in one tablet, which cost more. So you can even direct that. As you're working in primary healthcare center and not unlike other doctors who just want to do only the PHC and go to it, you want to just do outside the box and you have enrolled for the FCPM. So it makes you a responsible doctor, like unlike others. So the patient comes under geriatric framework, so you need to have the assessment first. So for these patients, ESAS, I think you heard the word ESAS, right? How do you take the assessment in palliative care? ESAS instrument, right? Have anybody listened or heard? Edmonton Symptom Assessment System Scale, which not only suffix this one, you need to take a geriatric comprehensive assessment in order to know, set the priorities, which problems, priority list, personalized care of plan, what interventions you need to do. So you need to do a CGA, which gives you the framework of all the physical, socio-economic, functional, mobility issues, psychological issues, medication review, financial issues. So you will get a framework of the problem checklist. And accordingly, the most distressing symptom, you can ask the patient among the all. And accordingly, you will have your intervention strategies, which one has to be given the first. So your medication should include, along with morphine, the co-analgesics, the steroids, which need to be not to be given for a prolonged period, and steroids should always avoid at night time if you're giving a BD dose, right, to avoid insomnia. So with PPI, and along with that, you give the gabapentinoids. If you have duloxetine, is very good. If you doesn't have, you can give IV methylcobalamin injections or the tablet form, whichever is available. And second thing is, you already said, how do you manage palliative care emergencies at PHC level? I was impressed by one doctor, that is Dr. Abhijit Dam. He works in rural West Bengal, Jharkhand, and rural Bihar setups, and among the tribal areas, where he goes along with the car and he sees the patient. As he says, the total pain concept, which includes physical, psychological, social, and environmental. The physical component is the 25% of the entire 100%, right? I don't say that without opioids management or doing palliative care is not much feasible or you have challenges. But what he said that even, and he doesn't have the opioids, but he tries to do the 75% of the component as much as possible. So it really is inspiration for most of the resource settings where one cannot have each and everything to be. Like for the emotional resilience, you cannot have a psychologist. Even in many corporate setups, you don't have a psychologist. The palliative medicine physician or the specialist, he becomes the psychologist, he becomes the nutritionist. He also at times be the more rehabilitation therapists, right? Resource settings are everywhere, limited setups are everywhere, and the challenges are everywhere. So you can give the IV steroids in your IV or the tablet form at PHC level. The same patient, you can prescribe paracetamol was not prescribed, which helps in bone pain. As you say, is frail. So you can give 500 milligram QID. You can give the dose. 2 grams is safer in liver failure patients as well, right? So even in cirrhosis or CLD patients, the maximum dose of paracetamol you can give 2 grams per day. As it is a PHC, you don't you do have morphine.
No, sir. No, sir.
So there is a nearby hospital. The anesthetist or somebody has given the epidural or something which you have mentioned in it. The
Yes.
hospital you can refer to the patient. They could have the oral morphine, which is less than the intervention procedures, or they might have methadone also. If they doesn't have the methadone, with co-analgesics you can do. At the same time, rehabilitation procedures, whichever is feasible. He has not taken radiation also. So if the nearby hospital, again, in spinal metastatic spinal cord injury, I have given the slide where there are challenges, patient per se, tumor per se, as well as the treatment per se, right? So, and he's alone. So the three most geriatric giants, that is dementia, delirium, and depression, they're more prone, geriatrics are more prone to that. So you should, what can we do? We can have this ASHA workers who goes to house or the volunteers, which you can give the responsibility for taking care of such patient as he's alone. As you said, impending paraparesis, he may definitely go to paraplegic, definitely, as he's alone, nobody to take care of, and he's nutritionally being deprived. So you can take over this issue to the Vidayak or the district collector or your community health centers nearby, where more doctors or the multidisciplinary team is present in CSCs. You can do a home care visits on Sundays or Saturdays, and you can involve the neighbors as to have a check on him, and if anything to report, so that you can take an action. So you need a multidisciplinary team approach. You can have them like ASHA workers to taking support, taking the multiple nearby doctors who can also be part of your team approach, and you can raise the funds. As it is a smart era, you can raise the funds with your YouTube or any channel where you can expose the patient for the fundraising. You can talk with the philanthropist. So these are the ways where you can generate funds. At the same time, you can even train the ASHA workers under your control, where how what to be taken, the Vidayak, that he's all alone. And even if he's dead, nobody ever gonna check him as well. So it's a really more than the paraparesis. I'm much worried about the rest of the domains where needs addressal, right? With the pain, as we always say, morphine or the methadone, they are not the wonder bullets or the magic bullets. The 40% pain max will be reduced at any point of time, right? It cannot be like 100% pain reliever or the single shot. You need to talk with the patient. You need to psycho-educate the patient. You need to counsel, and what more bothering him rather than the physical symptoms. What more you can able to do. That's why you have enrolled in FCPM to do much more. Like I have seen some of the IAS who done their MBBS or MD, and they shift to IAS for because to have a broader, wider spectrum of care or management, so that they can broaden their services. Similarly, you, unlike other PhD doctors or anybody, you want to do something more than this and outside the box thinking. So you have enrolled into FCPM. So you have to be an initiator. You have to take the lead, find out the channels where ASHA workers, volunteers, Vidayaks, sending the report to the district collector, involving. These things are much more plays a vital role, and geriatric rehabilitation is must, which as a first aid you can do with this co-analgesics, of course, the 100% pain relief may not be attained, but somehow at least 40% care could be given. And who will be the taken care of while during the emergencies, while if he is deceased unexpectedly, as you know, as spinal cord compression sets in, immobility is the major issues, and as cancer itself is a prothrombotic state, so embolus can happen because of the immobility issues at any time. Pulmonary embolus can take place, so sudden unexpected death. So your neighbor, the patient neighbors also should be included in the plan. Although they are senile and they are geriatric, they can watch out once a while, right? Daily once or daily twice, they can look into it. And if there is anything more resources to contact someone to report these issues. So you need to form a network of doctors, the nearby doctor who has given the epidural or the intervention. You can bring him on the spot. You can take help from him. You can even ask or make help, whichever is possible for that patient in holistic care. Right? We need to assess and we need to list out the problem list. What is the most distressing symptom that bothering the patient? And at any point of time, the pharmacology does help 40%, not the 100% of the things. So in this way, you need to channelize your problems. Of course, he has multiple systems. I feel multiple domains, right? He's being alone psychologically, the age factor, the comorbidity factor. He is in emotional turbulence. And of course, he has the spiritual pain, spiritual care, which we don't know whether he's an atheist or whether it doesn't correlate with the spirituality. So whatever he is, we need to total pain should be reduced instead of the physical pain. So even if we doesn't have any opioids, or if it doesn't have, we can at least make some sort of assistance in the overall care, which can help the patient at least 40%. Right? You need to involve many people, as well as the FCPM, as I say, an MBBS registered medical practitioner who has the palliative care certification. He can stock, and even without the palliative care certification, an MBBS doctor can stock not more than 500 mg of morphine, right? And two fentanyl patches he can stock, 12.5 mics and 25. So even without palliative care certification, there is a government, the NDPS Act provides that 500 mg of morphine can be in stock, like a first aid. For methadone, NDPS has not set up any limit, like how much it should be, like morphine and fentanyl. With this, you can collaborate with your local morphine vendors. You can have your NGOs. You can have philanthropists, which can help the patient overall. Right? I think you should start steroids for this patient, monitoring the diabetes, and start co-analgesics, and track the multidisciplinary team approach involving the ASHA workers, ASHA DAIs, right? Somewhat it will help him raise the funds, take the scenario, the patient to your community health centers, vidayaks, produce this case or make a report to the district collector, and also raise funds in the smart era technology and involve the neighbors so that they will also be the part of the treatment plan. And they are the only caregivers, informal caregivers, at least once a while they can see, and the volunteers, which play, I think, the paramount level in palliative care. The first most position goes to the volunteers, nurses, and I really say that bottom line is the doctors, right? So the volunteers and the nurses, the medical social workers, they play the major role, and taking their help into this case scenario, this patient definitely you can have some leads.
Yes, sir. Thank you so much, sir.
Yeah.
Thank you so much, Dr. Ravi sir, for that wonderful discussion and for the wonderful presentation. There was only one question in the chat box, like how can we treat DKI and severe hyponatremia at home-based care?
Again, we need to see whether it is malignancy, non-malignancy. If it is a malignancy, there is a paraneoplastic syndrome where you can get hyponatremia, hypercalcemia as such. And you need always consider the phase of the patient in the palliative care, whether it is end of life care or whether he is active or currently receiving therapy and he is on hyponatremia. So these conditions to be taken care of, whether he is in cachexy and there is no IV line secure. So many factors do play a role. And the best shot for the hyponatremia is the IV 3% NS or at least a RL or NS line, which can go. But at the same time, you need to know the intent of your therapy, your goals of your therapy. You need to predefine it, whether you want to save the patient or comfort the patient. So these two are the extremes of a patient care spectrum. It's a really opposite ends. So you need to predefine your goals. You need to predefine the priorities, and you have to proceed further and always correctable within your horizons. As Dr. Rajgopal sir, you said, I was really like, you are not almighty that you can eradicate the entire misery of the patient, right? You can only wipe out the patient misery or the sufferings to some extent in human range, whatever it is possible in your hands, and justify whatever you do. Not like randomly that it have some thought out of the blue and has been done. You have to justify your step, and wherever you justify, it's never wrong and it's never illegal too, right?
Thank you so much, Doctor. There are wonderful
Yeah.
comments in the chat saying that it was a great lecture with a beautiful
Thank you, but most of the participants are being dull, maybe because of post session or I don't know, but I have to go through it. But please go through your previous lectures of pain and the opioid rotations and how do you convert into it. It's much more helpful for you, right? Thank you.
Thank you, sir. Over to you, Gayatri.
Thank you so much, Dr. Ravikiran, for the wonderful and interactive session. Thank you all participants for joining. I hope you all found this session much informative. We are looking forward to see you on the next session. Thank you all.